a topic that is very near and dear to my heart, the Rochester Epidemiology Project, which we also call the REP. So together with Dr. Walter Roca, who is a neurologic epidemiologist, the two of us co-direct this project. So today I'm going to tell you a little bit about what the REP is. I'll talk about some of the studies that have been done using the REP, and I'll finish up by showing you our data exploration portal to give you a feel for the types of data that are available through this research infrastructure. So what is it? It's a research infrastructure. And like any infrastructure, the goal of the REP is to get investigators where they need to go as quickly as possible. So as the REP team, we try to do a lot of work behind the scenes to make it easy to conduct epidemiologic research. And that is something that is unique about the REP in terms of research infrastructures, in that we really do try to optimize our infrastructure so that it's easy to define populations at given points in time and to easily conduct epidemiologic research and minimize bias. What we do is we link together the medical records of Midwest USA residents from multiple sources of healthcare. We also facilitate access to medical records from multiple institutions, and we archive and maintain access to historic medical records. Our goal has always been to provide a more complete picture of health and healthcare and health outcomes for residents of a particular region in the United States. The REP can serve as a sampling frame to actively invite people to participate in studies, but then you can also passively follow residents of this region through their medical records. And just to give you a feel for where the REP region is, so here's the United States, and then here's Minnesota, and right next to us is our neighboring state of Wisconsin. And you can see the REP region is this sort of backwards L-shaped region. It's a 27 county region. Historically, the REP has focused on people residing in this region. This is Olmsted County, Minnesota, and this is where I'm sitting right now. The REP actually began back in 1966 through a partnership between investigators at Mayo Clinic, Olmsted Medical Center, and a number of private practitioners in our region. Over the years, there have been other practitioners who participated in the Rochester Epi project, and beginning in 2009, we expanded fairly dramatically through inclusion of the clinics and hospitals that are part of the Mayo Clinic health system in this region. Beginning in 2011, we started to incorporate data from a number of dental practitioners, and Olmsted County Public Health Services joined us in 2014. Our most recent partner is Zumbro Valley Health, and we were especially excited about their joining the Rochester Epi project because they serve a very unique patient population. They focus in on patients with substance use disorders and severe mental health disorders. And that's really why the REP is important, because I think probably everyone on this call knows healthcare in the USA is very fragmented. And typically, if you're at an institution like the Mayo Clinic or another referral center in the United States, you really only know what is happening to your patients while they're under your care. The REP, by linking together medical records, can provide a more complete picture of all of the healthcare delivered to a single individual. So let's just take the example of John Smith, who was an Olmsted County resident in 2010, and he received all of his primary care through Olmsted Medical Center. In February of 2013, 3 years later, he ended up in the Mayo emergency room for a heart attack. And then after he recovered, he went back to his primary care provider in March of 2013 at Olmsted Medical Center. Typically, if you're an investigator at Mayo Clinic and you want to know risk factors for heart disease, you want to know what happened to John Smith before he ended up in your emergency department. Or if you've tried a new therapy or a new procedure and you really want to know what happened to John Smith after he left Mayo Clinic, again, you need access to his healthcare information after he leaves the doors of Mayo. And that's really what the REP does, is our team spends a lot of time linking together the medical records from these multiple different sources of healthcare to unique individuals. So again, because healthcare is so fragmented here, we don't have unique identifiers, and it can be hard to tell if John Smith, who was treated at Olmsted Medical Center in 2010, is the same as John H. Smith, who was treated at Mayo Clinic 5, 6, 10 years later. So our team spends a lot of time trying to make sure that these medical records are matched to the correct individuals residing in this region. These medical records come attached to electronic data, including demographic data, prescription data, procedures, and diagnoses. And each of these pieces of information comes attached to a date, the date of the visit at one of these healthcare providers. And using these dates and this information, we can create timelines for the unique individuals who reside in our area of coverage. So we make timelines for everybody that we touch within our system. Let's just take the example of this person. If you think of each visit to a healthcare provider as a pin in a timeline, you can see that this person entered our region at around age 29 through a visit at Olmsted Medical Center. This person moved back and forth to different healthcare providers for different reasons over the years before dying in our region at age 61. By definition, all REP studies really focus in on residents of our region. So we can often follow people when they move in and out of our region because all of those little pins that I showed you earlier also come attached to address information because medical care providers in the US need to know where to bill for their services when somebody receives care. So using those addresses, we determine whether or not a person in our system was a resident of our region or not at any given point in time. And so you can see here, the person I showed you on the previous slide was a resident during this time, moved away, and then came back. These pins are discontinuous, however, and to really work with them functionally as an epidemiologist, we needed to turn these into continuous timelines. So everyone in our system now has a continuous timeline. And if they have a green component to their timeline, they were a resident of our region. If we're not sure, but we think they were, they get a little yellow component to their timeline. If they were not a resident of our region, they get a red component. And if we think they weren't, but we're not sure, they get an orange component. And these timelines turn out to be very useful for conducting epidemiologic research studies. So again, everyone in our system now has one of these timelines. And you can see that these timelines are of different lengths. They stop and start at different points in time. And we do track people sort of as they move in and out of our region. What these timelines allow us to do is to draw essentially a vertical line at any point in time where we want to do a research study. And if the vertical line goes through a green or a yellow component of a timeline, that person is a resident of our region and is potentially eligible for our study. So by doing this, we can enumerate the population, and we have very nice denominator information then for incidence and prevalence studies. But we also have an excellent population-based sampling frame for selecting controls for case control studies, or for selecting population-based reference for cohort studies. So investigators often also want to know how much information is available in the REP. Again, the REP started back in 1966, so we have decades worth of information for the Olmsted County population. And let's say you're interested in doing a study in 1970 on this population. If you're doing a case control study, you want to know how much information is available prior to that date. If you're doing a cohort study, you want to know how many years of follow-up are available for this particular population. And because we started back in 1966, and because we have very good capture of this population, we have extensive amounts of information available for this population. It does vary depending on the calendar year of the study you're interested in doing, and depending on the age of your population. So let's say you're interested in doing a study in 1970, and you're focused in on persons 40 to 49 years of age. The median number of years of information available for this population prior to 1970 is nearly 15 years worth of information. The median follow-up information is over 3 decades. So about 35 years is the median amount of medical record follow-up information. Of course, as you move closer to the present, the years of historic information stretch back and the years of follow-up get shorter. We're closer to the present, of course. And so if you're doing your study in 2010 and you're again focused on 40 to 49-year-olds, you have a median of about 24 years of information available prior to that date and a median of 10 years of follow-up available. And this is something that makes the REP really unique because it has allowed investigators to look at exposures and outcomes that can sometimes be separated by decades. We don't have a lot of people in this region who are born here, live their entire lives here, and then die here. But we do have a lot of children who are born here, live their childhood and young adult life here before leaving for school or to take a new job. We also have a lot of adults who move here to start a career and to establish families here, and they can live here again for decades. And finally, we do have a lot of people who retire here and live out their aging years in this region. And so what this allows people to do is to really follow individuals over the course of their lifespan and conduct lifespan research. The types of electronic or structured data we have available to us are the types that I think probably most people are familiar with through these types of research infrastructures. So we have electronic demographic data, medical diagnosis and surgical procedures like ICD codes. We have drug prescription information. We have laboratory test results, and then we have services and procedures. But something we have always insisted on is that we always link back to the full text of medical records. And that's because we just know that the clinical notes just contain a wealth of information that investigators often want to mine and abstract and review to get details that are not really fully captured by some of this electronic kind of high-level extracted data. Of course, since the REP started back in 1966, we are talking about dealing with a lot of paper medical records, sometimes with very, very bad handwriting. Some of these physicians really live up to the stereotype of having horrible, horrible handwriting. And people do spend a lot of time trying to decipher some of these notes. Of course, over the years, we have moved into electronic health records, and now all of our partners use some form of electronic health record. And it's really important to us to maintain a copy of the full text of these medical records and these medical notes. And we do this in different ways now. So we have large warehouses where we store the paper records, and we pull and scan these on demand for research studies. And then we provide access to electronic records, even if they are being purged from the different healthcare providers that participate in the REP. So as I mentioned before, REP studies have historically focused in on residents of this single county, this Olmsted County region. However, Olmsted County in 2020 had a population of about 155,000 unique individuals. And that actually is just too small of a population for studies that are involving rare conditions or outcomes. So beginning in 2010, we expanded into this 27 county region. And what this gave us was an increased sample size. So we can now study less common diseases. We can study very specific age and sex groups. We can study specific race and ethnic groups that are minority populations in our region. Also, we have larger sample sizes, so we can look at things that we expect to have weaker associations. And we say that we can now look at urban versus rural populations. Alex could tell you that we are a relatively rural community, and we're a pretty small city. We're much smaller than, say, Minneapolis or St. Paul. So even our larger city in the area is relatively rural. But by moving into this 27 county region, we're really moving into a very rural population, and it's predominantly dominated by farming communities. So we can start doing studies looking at kind of urban versus rural populations. And we also get much more diversity in terms of socioeconomic status. So it is a trade-off for us because we are moving from a county where we essentially touch everybody in the population. So we have at least some healthcare information on everybody who lives in Olmsted County. By moving into this 27 county region, people have the opportunity to go to other healthcare providers that do not currently participate in the Rochester Epidemiology Project. And because of that, our coverage of these populations does decline, and it will vary depending on the county. In this region, the 7 county region that's outlined in pink, we still have very good coverage. And so we touch about 94% of the population that resides in these 7 counties. In the entire 27 county region, we touch about 61% of the population. These next couple of slides are just going to show you the diversity in terms of some of the characteristics I mentioned before. So in terms of persons living below the poverty line, we're moving from Olmsted County, outlined here in blue, where we have about 9% of the population living below the poverty line. As we move into these other counties, you can see we get much more variability, ranging from about 7% to about 17% of the populations in these regions residing below the poverty line. Also, we are very rural and we're very white. And so the proportion of our population that is of a non-white race or ethnicity is about 14% in Olmsted County, and it declines fairly rapidly throughout the rest of this region. However, even though the proportion of our non-white population is lower, the absolute numbers of this population increase dramatically with this expansion. So we can now do much better studies of persons of a minority race or ethnicity. We also get a lot more diversity in terms of education status. So Olmsted County is the home of the Mayo Clinic, and it's home of another large healthcare provider, Olmsted Medical Center. And the population that resides here is very well educated. About 40% of the population is college educated. As you move into these other communities, that proportion decreases fairly dramatically. So we have much more diversity in terms of educational status. And even though we are a small community with a very small city, we are considered 83% urban. And I always want to put quotations around that. But as you move into the larger community, you can see that some of these counties really have 0% of the county are considered urban. So we touch 60%, about 60% of the population that resides in this region. And we needed to know whether or not the population that we capture is reasonably representative of the underlying population. So these next couple of slides are going to show you our comparison of our captured region versus US Census data. In terms of age and sex, we essentially look like the underlying population. And we look essentially like the underlying population in terms of race and ethnicity, and in terms of the older population. Our captured population still is slightly more well educated compared to the actual underlying population. When we compare our captured population to the Upper Midwest region, and those are the 5 states that kind of surround our area, we look the same essentially in terms of age and sex. We're very similar in terms of race and ethnicity, and in terms of age, and in terms of bachelor's degree. However, when we compare our captured population to the entire US, you can see we're similar demographically and relatively similar in terms of education, but we are much less diverse compared to the rest of the United States population. So our minority population is smaller, and it's just a function of where we're located. Our Upper Midwest region just has a smaller proportion of persons who are non-white or who are Hispanic. So that means that we have to be cautious when generalizing the results of our study to other populations, as every study needs to be. So with the expanded REP, we're moving from the Olmsted County population, where we have decades worth of data dating back to 1966, and about 550,000 unique people have resided in Olmsted County, dating from 1966 to the present. These people have about 2 million patient records from different sources of healthcare that they used while they were a resident of this region. Just by division, you can see that on average, everyone in this system has about 3 medical records per person. There's a huge range here. So I'm an Olmsted County resident, I'm a Mayo Clinic employee, I've gotten all of my medical care at Mayo Clinic. I only have 1 medical record in this system. But we do have 1 person in our system who has 24 different medical records from 24 different sources of healthcare they used while they were a resident of the region. When we expanded to the 27 county region, we have the trade-off now where we have less follow-up available. So these data start in 2010, but we move from 550,000 unique people to about 1.8 million unique people. And we move from about 2 million records to about 4.5 million records. So because there are more sources of healthcare available to people in this region, we move from an average of 3 medical records to about 3.7 medical records per person, and our range expands a bit as well. So we tend to use Olmsted County, or that 7-county core region where we capture about 94% of the population, when we're doing our classic epidemiologic studies, where we really need to know very good denominator data, and we want to know that we have virtually complete capture of our numerator. So for the classic incidence, prevalence, descriptive studies, we tend to focus in on that population. However, we can easily move into the 27 county population when we need larger numbers. And this region has been frequently used lately as a sampling frame to contact people and invite them to participate in active studies. And it's also a great sampling frame for doing case control studies. So just to briefly summarize, some of the advantages of rep data for the United States in particular is that the data are available across all ages and both sexes. It's focused on people who reside in the region. So it's not based on specific characteristics where persons are recruited because of those characteristics. All of the data are linked and coded. And at least for the Olmsted County population, we have decades worth of information. And finally, we really do think this is extremely important to always be able to link back to the full text of the medical records. So I'm going to switch gears a little bit and talk about some of the studies that have been done using this REP infrastructure. So currently, we are supporting 38 federally funded grants. These are funded through the U.S. National Institutes on Health. Many of these grants encompass multiple projects, but apart from these grants, we also support a lot of projects from just a huge range of investigators. So right now we're supporting 437 active projects. These projects engage 97 external collaborators. So these are collaborators whose primary appointment is not at Mayo Clinic, but they are partnering with someone at Mayo to conduct a Rochester Epi Project study. Trainees often use this research infrastructure because it's set up in a way to make these studies faster to do than the average study. They don't have to start from scratch. So currently we're supporting 273 trainees on these 437 active projects. And the REP has supported more than 3,000 peer-reviewed publications since 1966. It was a little difficult for me to decide what to show you in terms of REP studies. So I'm just going to show you a range of some of the REP studies that have been highly cited. So in these next 3 slides, each of these studies have been cited over 300 times by investigators in different areas. This study is just the epidemiology of community-acquired C. difficile infection. This was a population-based study focused on residents of Olmsted County. And this was a very classic descriptive epidemiology study where the investigators identified incident cases of C. diff. They did a thorough chart review to obtain information about each of those cases. And they found that 41% of these cases were community-acquired as opposed to hospital-acquired. And in general, these cases were less severe and tended to be in younger patients. And one of the takeaways from this study was really that by focusing in only on C. diff infections that are occurring in the hospital, you may end up with some biased results, and that it could be very, very important to detect and incorporate community-acquired cases. This study is an example of a pediatric cohort study that's been done using the Rochester Epi Project, focused on cognitive and behavioral outcomes after early exposure to anesthesia and surgery. These investigators used the REP to identify children who had anesthesia for a procedure prior to age 2, and then they matched them to children who did not. They also established a partnership with our local school district, and they were able to link these children to their school records from later in life. And they found that children who had multiple exposures to anesthesia prior to age 2 were at an increased risk of learning disability. And finally, the REP is probably most frequently used for studies of the adult and aging population. And this is just an example of an adult active follow-up study where the investigators invited a random sample of people living in the community, 45 years of age or older, to come in for a complete physical exam. They then used the medical records that were linked through the Rochester Epi Project to follow them up for a diagnosis of heart failure. And they found that diastolic dysfunction was associated with development of heart failure. So each of these are individual papers, but people often incorporate REP studies as part of building a research program. And I'll just walk you through a couple of recent examples. So that study I showed you, the paper I showed you was done by Dr. Warner and Dr. Flick looking at anesthesia and neurodevelopmental problems later in life in children. These studies have really prompted changes in national and international guidelines on when and the timing of doing surgical procedures on children. In particular, the concept now is that if you can delay some of these surgical or interventional procedures on young children, it might be better for their development later in life. One of the best known Rochester Epi Project studies is the Mayo Clinic study of aging led by Dr. Ron Peterson. And this is a project that Alex knows very well because she worked on it while she was here at Mayo Clinic. But some of their studies of neuroimaging, where they invited persons residing in the Olmsted County population to come in for neuroimaging and other exams, these studies have really served as the basis for the new classifications of preclinical stages of Alzheimer's disease. Dr. Walter Roca is a world-renowned neurologic epidemiologist, as well as being, of course, my co-PI on the Rochester Epidemiology Project. More recently, he's expanded into research on bilateral oophorectomy. And he's done extensive research looking at bilateral oophorectomy in premenopausal women and has linked early oophorectomy in the absence of hormone replacement therapy to long-term sequela and accelerated aging. And these studies are changing guidelines for the prevention of ovarian cancer. I've worked more locally with investigators in looking at studies of human papillomavirus vaccination, HPV vaccination. And in our community, HPV vaccination rates are abysmal. They're really pathetically awful. And so using the rep research infrastructure, we were able to identify the populations that really seem to have the lowest vaccination rates and to dig into factors that may influence HPV vaccination. And those first studies really prompted the initiation of an ongoing randomized pragmatic intervention trial focused in on both providers and parents to try to modify behaviors and influence HPV vaccination rates, hopefully in an upward direction. And finally, the rep population is a good environment for studying the deployment of new therapies or new treatments or new diagnostic tests. So recently, we've also used the rep population to study the deployment of a Cologuard. This is an at-home colorectal cancer screening kit for the screening of colon cancer. So we've been using the rep to study the deployment and the use and prevention of colorectal cancer outcomes. I'm going to switch over now to show you our data exploration portal. So we developed this really to try to share rep data with a larger audience. I do want to emphasize we consider it an exploration portal. It's exploratory and it's not designed to replace a full study. And you really shouldn't publish the results, but you're more than welcome to kind of explore associations that you might be interested in examining in a larger study. So I'm going to stop sharing here, and this worked when I tried it earlier, so we'll see if it works again. So can you see that okay? Okay. Anthony's nodding. Good, good. So if you go to our webpage, we have this rep data exploration portal, and this is our home tab, and it just talks a little bit about what it is. But if you click on the Explore tab, you're going to get a page that looks like this. So what you can do is you can select characteristics, diagnoses, procedures and services, medications, or personal characteristics that you might be interested in exploring within this 27 county population that I've been talking about. You can look at it over a 5-year period or a 1-year period. And to watch, this is not going to work for me now. Let me see if I can. Okay, there we go. What you should be able to do is click here, and you can start typing a disease or a condition that you're interested in studying. And I'm just going to type zoster, and I'm going to select herpes zoster infection. So for those of you who aren't familiar with this, herpes zoster is a very painful sequela to essentially chickenpox infection or the herpes zoster infection. So what you can see when you type in your characteristic and you select your characteristic is first you can see what things are included within this category. And you can do that by clicking on this list of codes. When you do that, you can see that each of the categories we have in this portal are an aggregate category of other underlying conditions. And typically they're ICD codes or CPT codes. What you can also do then is you'll get a display of the prevalence of whatever it is you're looking at in this first panel. And so you can see the prevalence per 100 persons of herpes zoster infection. And again, this is in our 27 county region. So the prevalence is quite low in the younger population. It increases with increasing age, and zoster infections are higher in women, this red line, compared to men, this blue line. You can select a second characteristic, and I'm just going to type in diabetes here. Whoops. I guess we'll stick with diabetes with complications, so you don't have to wait for me. And you can see diabetes mellitus with complications in our population, again, quite low in the younger population, increases dramatically with increasing age, and is more prevalent in men compared to women. You can look at a 5-year prevalence, or you can look at a 1-year prevalence. And similarly here, we can look at a 5-year prevalence or a 1-year prevalence. When you select 2 characteristics, you're going to get 2 more panels. So this panel down here is just showing you the prevalence of the co-occurrence of these 2 conditions in this population. You're also going to get an observed to expected ratio. And what this is going to tell you is whether or not the characteristics you are selecting, whether or not they're going together more often than you would expect due to chance alone. So if you're leaning more toward the orange shading, the observed to expected ratio is stronger. If you're leaning more toward the blue, they're going together less often than you would expect due to chance alone. If the numbers have a star, then they are statistically significant. And so what you're seeing is that overall, diabetes mellitus with complications and zoster are co-occurring more often than you would expect due to chance alone. And this actually seems to be a fairly strong association in the 21 to 39-year-olds. You can also see that the numbers are quite small. So some of these panels are grayed out because the numbers are too low. You can also click on this geography tab, and you can take a look at the prevalence of whatever it is you want to study in this region of interest. So you can see if you scroll over in Olmsted, the prevalence is about 4.31 per thousand. In Freeborn, it seems to be the highest, and in Pepin, it seems to be quite low. And finally, I'm just going to click on this trends. I'm going to display the zoster infection. I'll mention that our entire group really got hung up with receiving new data during the COVID pandemic, so I apologize, these data are out of date. We are hoping to have this updated through 2018 by the end of July, but for now, you got 2012 through 2016, so it's a little bit old. But what you can see here is this is the prevalence of zoster infection, the 1-year period prevalence between 2012 and 2016. It's higher in women consistently compared to men, but it's pretty flat. It's not really going anywhere. In the youngest population, we are seeing a decline, which is really interesting. Again, it's rare in this younger population. This is the prevalence per 10,000 persons. So you can see this is these numbers are quite small, but we are seeing a distinct decline. And that's not really seen in some of these other age groups. In fact, it may be going up a little bit in some of these age groups, pretty flat in the older age groups. What we know in the United States is that with the introduction of the chickenpox vaccine as a standard vaccine that's administered in young children, other groups as well are starting to see a decline in shingles in the children who have been vaccinated with the chickenpox vaccine. And so again, it's rare in these young adults, but as these children who receive the vaccine get older and older, we should continue to see these declines in shingles. In addition, we have a very good zoster vaccine now that we use in persons 50 years of age and over, and we would expect to start seeing declines in these older populations as well over time. So I'm going to stop sharing, and I'll go back to my slides. So there are a number of limitations of this portal. The groupings may not all be useful for particular studies. We did our best to try to define our categories in ways that conform to national categories and standards that people would recognize. But often people want to study a subset of those particular larger groupings. Our age groups are fixed. If you're really focused in on children 0 to 5 years of age, you can't really do that with our portal because our youngest population is a larger age group. Or if you want to study, say, just younger women between 15 and 35, you can't really do that with the portal. So it's meant to be just kind of a broader way to explore some of these associations. We also just want to remind you that we touch about 60% of the population. It's in this 27 county upper Midwest region, and results could be biased and they may not be generalizable. And so we do really recommend people just use it to explore ideas that they might have, but maybe do a correct epidemiologic study. So in general, rep studies have really been ideal for understanding the health and health outcomes in our local population. These studies do tend to be less biased than referral-based studies because they're population-based. They're just based on people who are living in this region. And they have served as a useful component in building many research programs over time. We are currently funded by the National Institutes of Health, and we have been continuously funded by them since 1966. We have switched institutes over the years, and we're funded now by the National Institute on Aging, and we're also funded by the Mayo Clinic Research Committee. Recently, we have had to start charging for use of the rep. Prior to this year, use of the rep was free, but now these studies require a data access fee of $3,000 per project per year. We do have a lot of further information available on our external website, and you're more than welcome to email me directly with any questions, but we also have a general email box, just info@rochesterproject.org, that is manned by our team, and you're welcome to use that to ask us any questions. And finally, I just want to show our rep team. So together with Walter Roca, and Dr. Alana Chamberlain, who is a cardiovascular disease epidemiologist. We lead the Rochester Epi Project, and we have a management team, an IT team, and an operations team. And again, you can see our funding at the bottom of the slide. So I'll stop there and just thank you for your attention, and I'm happy to take any questions.